Morning, everyone. Uh, this is another Monday where we will discuss a very important topic. When we see our patient in palliative care settings, we find many a times patient and their relatives are, and even ourselves, we really find it difficult to manage a patient who is having excessive salivation, and this becomes sometimes a big problem for patients and their attendant. Uh, we advise them many things, but how to handle and how to approach such patients systematically. For this, now we have a team of doctors, Dr. Bhawesh and Anuja. They are from AIMS New Delhi. Anuja is our faculty in our department, and she is first DM students of this whole of the country, I think. And she is also working very hard in development of pain and palliative care. Beside this, she has got a lot of awards in various conferences. She is attending conferences regularly and getting all sorts of award, which is possible by initially by a student and by a young faculty member. She's regularly teaching and taking classes for palliative care students and on cancer pain management. Bhavesh is our MD palliative medicine, post MD palliative medicine. He's doing senior residency in our department, attended various conferences, presented papers, and both of them are brilliant student of our department. And now Anuja is teaching and training other students. So with this, I think I will start that how to approach, and even I'm looking forward that what they have brought systematically, how to approach a patient who is having excessive salivation. Anuja, go ahead, please.
Thank you so much, ma'am, for the kind introduction. So, good morning, everybody. The thing with sialorrhea is that, first of all, it's not a very discussed symptom. But even when you discuss it, our knowledge is usually limited to management. But it is also important to know the etiology, the mechanism of sialorrhea, and why it is such a distressing symptom. So, Bhavesh has really highlighted well in the presentation. So, Bhavesh, please go ahead.
Thank you, ma'am. Thank you, ma'am, for the introduction. Today we will be good morning, everybody. Today we will be discussing the challenges and palliative care for the patient with sialorrhea. As ma'am has already discussed that it is one of the very less discussed topics, so it was really difficult also to find the data regarding it. We have tried to highlight the issues of the sialorrhea. So coming up to the outline of the presentation, today we will be going first by the introduction, then we will see the salivary and swallowing reflexes, then we'll see the mechanism and the causes of sialorrhea, then we'll see the issues which are faced by the patients, and then we'll go on the management part, dealing with first of all pharmacological treatment and then non-pharmacological treatment. So coming to the introduction, sialorrhea, also known as drooling or telesis, is a debilitating symptom that occurs when there is excess saliva in the mouth beyond the lip margin. So saliva is produced by salivary glands. Almost 1.5 liters of saliva is produced per day. There are major salivary glands and minor. The major are two parotids, two submandibular and two sublingual, and there are many other minor salivary glands. So these are present for salivation. Coming up to the drooling is common in normal developed babies, but it subsides by 15 to 36 months. And it is considered abnormal if it is still present after 4 years of age. As already discussed, the major salivary glands include parotid, submandibular, and sublingual. And among these, the largest is parotid gland. Parotid produces the largest volume of saliva. But there's when there is no any suppose the patient is in there's no exciting factor. So at that point of time, submandibular or sublingual glands produce most of the saliva, But when there is any exciting factor like there is food or any light and touch or water, then parotids are the glands which produce most saliva. Saliva production is completely controlled by external factors, by autonomic nerves, and both by sympathetic and parasympathetic divisions. So coming up to the salivary reflex. The afferent branch consists of chemoreceptors in taste buds and mechanoreceptors is periodontal ligaments. Afferent innervation is by cranial nerves 5, 7, 9, and 10. That is trigeminal, facial, and glossopharyngeal and vagus. Also, they also carry impulses to salivary nuclei in medulla oblongata. The afferent influences are mainly by parasympathetic via cranial nerve 7, which control the submandibular or sublingual gland, and other minor are controlled by cranial nerve 9, which influences the parotid gland. So the parasympathetic stimulation is by the acetylcholine. So the mechanism part will also, the mechanism and the treatment part will also be related to acetylcholine only. Here is a diagram where we can see the afferents and efferents. As already discussed, the mechanoreceptors and the chemoreceptors present in the taste bud and other ligaments in face oral area, they carry the afferents by 5, 7, 9, and 10 vessels, cranial nerves to the salivary nucleuses. And then the efferent are taken by 7 and 9. Coming up to the swallowing reflex, the afferent pathway receptors are located in oropharyngeal spaces. Oropharyngeal spaces include soft palate. There's dorsal side of the tongue. Uvula also is included there. Other than that, facial pillars in the oral area are the area which are most sensitive to any stimuli. These receptors can initiate swallowing while responding to water and light touch. Primary efferents from the receptors in the oropharyngeal mucosa travel in the trigeminal, glossopharyngeal, and vagus nerves and converge in the solitary tract destined for synaptic contact with the second order neuron in the nucleus rectus solitarius. What it means is these receptors they convey the afferent pathway through the 5th, 9th, and 10th nerve, and then they converge in the solitary tract with the second order neuron in the nucleus rectus solitarius. From there, what happens is there are, as you can see in the diagram, there are swallowing centers. So nucleus rectus solitarius then initiates and gives a positive response to swallowing centers, which are dorsal swallowing group and ventral swallowing group, and then through the efferent pathway. Efferent pathway is through 5, 7, and mainly ambiguous and hypoglossal nuclei. Through there, the efferent pathway is taken up, and the swallowing reflex has been conducted. Ambiguous and hypoglossal nuclei activate all their motor neurons during the act of swallowing and are considered to be the part of motor nuclei involved in the function. So coming up to the swallowing reflex, here we can see. So first there is chemoreceptors and mechanoreceptors, which through the 5, 9, 10 nerve, they initiate the swallowing arc to the nucleus rectus solitarius, which give positive reinforcement to the swallowing centers in dorsal swallowing group and ventral swallowing group. These are also affected by the higher centers through the cerebellum or cerebral cortex. Cerebral cortex gives us the feedback, peripheral feedback, especially by the pharyngeal muscles, the reflexes which come, and also by the chest wall. This is important because swallowing and respiratory action is all taken by almost the same pathway. So when respiration happens, the swallowing has to be stopped. So this has been taken up by the higher centers, by the peripheral feedback, also by both these centers, respiratory centers, swallowing centers. So they negatively affect each other. Also, coming up to the factors which affect swallowing. it can be muscle weaknesses. Muscle weaknesses can be due to any pathological of the neurons, just like myasthenia gravis or any other causes. Other than that, body posture is also responsible for the swelling postures, swelling reflexes. Sitting position, it is better that the swallowing happens and the food does not pass into the glottis. And while in the supine position, it is very much possible that the food will trickle down to the trachea. It is also said that epiglottis itself is responsible for stopping the food, especially when the patient is lying supine. When the patient is sitting position, what happens in the hypolarynx, it comes above and it can also stop the glottis. But in supine position, it is important for us that epiglottis is functioning, and it is generally recommended not to eat or drink in supine position just because the glottis is not covered. Other than that, timing is also very important for the swallowing reflex. Usually, swallowing happens in the expiratory phase of the respiration, but due to some pathology, it can be deranged and it can further lead to aspiration. So coming up to the mechanism of sialorrhea. Now, sialorrhea is basically, it can be due to increased production of saliva, that is called hypersecretion. That can be due to inflammation, such as teething, dental caries, or oral cavity infection. It can be due to it can be drug induced, can be due to side effect of the medications patients are in. It can be due to GERD, gastroesophageal reflex. It can be due to that. And it can also be due to toxic exposures or rabies. Other than hypersecretion, the other causes are neuromuscular dysfunctions, sensory dysfunctions, and anatomic dysfunctions. Neuromuscular dysfunctions are the most common causes of sialorrhea. Neuromuscular activity of swallowing involves efficient coordination of several structures, including oral cavity, pharynx, larynx, and esophagus. So if something happens in any of these phases, any of these structures, if there is any deformity or if there is any pathology, so the swallowing reflex will be deranged, and that will lead to that the saliva is not the saliva is present in the oral cavity only, and it will trickle down out of the oral cavity. So these structures form three phases, which will be oral phase of the swallowing, pharyngeal phase, and esophageal phase. Pharyngeal and esophageal phase are involuntary controlled, and oral phase is voluntary controlled. Now coming up to the causes of each of these causes which we just highlighted. So neuromuscular and sensory dysfunctions. The main causes are mental retardation, cerebral palsy, Parkinson disease, bulbar palsy, and stroke. Cerebral palsy is one of the most common cause in children, and Parkinson's disease is one of the most common cause in adults. The causes of hypersecretion may be inflammation, that can be due to dental caries, oral cavity infection, rabies, medication side effects, drug induced. It can be due to, we'll see which are the drugs which cause hypersecretion. Gastroesophageal reflex disorder can be one of the cause. Toxin exposure by mercury vapors can also be one of the cause. So coming up to the drug causing hypersecretion, they can be analgesics like buprenorphine, mefenamic acid, ketamine, antibacterials like gentamicin and dobramycin, anxiolytics like alprazolam and clonazepam, cardiac drugs like amiodarone, cholinergic agonists like pilocarpine and acetylcholine, other psychotropics like clozapine, haloperidol, lamotrigine, risperidone, and venlafaxine. Other than that, there can be anticholinesterases like neostigmine and pyridostigmine, iodines, levodopa, and rivastigmine. So these are one of the major drugs, and if the patient is on one of these drugs, we should, and if the patient has complained of sialorrhea, so we should consider changing the drugs. Coming to anatomic reasons and anatomic causes by themselves, they usually do not cause sialorrhea, but if they're accompanied by any other cause like hypersecretion and neuromuscular disorder, they can lead to sialorrhea. Now they can be macroglossia, that is enlarged tongue, oral incompetence, dental malocclusion, orthodontic problems, and head and neck surgical defects. Uh, so in children, the most common cause of sialorrhea is cerebral palsy, which persists in 10 to 38% of these individuals. In adults, Parkinson's disease is the most common cause, with 70 to 80% of Parkinson's disease patients demonstrating sialorrhea. In schizophrenia, 30 to 80% patients have hypersalivation due to the drugs they are taking. That can be example of clozapine. Other causes other than that are head and neck diseases such as ALS and head and neck cancers. Now coming up to the assessment, how we will assess the sialorrhea patient. So first of all, a proper history should be taken to know the pathology and to know the cause. What are the causes which are leading to the sialorrhea? Drug history is to be noted. Any other history of patients suffering from any other disease has to be noted. And if the patient is not a known patient of any other pathology, then the workup for that should also be done. Therefore, the assessment needs a multi-team mm, a multi-team people, so which will include neurologists, which can include ENT surgeons, which can include speech therapists, which will also include any other therapy physicians if required. On physical examination, we have to first evaluate the general physical examination. Then on coming up to the systemic, we have to evaluate the cranial nerve examination, because there are various cranial nerves that, as previously discussed, are important in the taking part of the salivation and salivary swallowing reflex. So we should properly examine cranial nerve examination. Assessment of any anatomical abnormalities present in the oral cavity. Functioning of oropharyngeal muscle functions is also very important. If there is less tone of oral muscles, or there is paralysis of oral muscles, so that is one of the cause. That can be one of the cause. Evaluation of alertness, overall motor skills, sensory abnormalities, and dysphagia has to be evaluated. Now, other than that, there can be objective tests which can be used. One of those is radioisotope scanning. They are rarely used. Other than that, measurement of the amount of salivation can be done by chip churn cup collection or soaked bib weights. What we do is we connect the patient with a cup and hold it by the chin. So whenever the patient has to salivate, the patient puts the saliva in the cup or in the soaked gauges, and we can weight them afterwards. So that by that way, we can get a objective measurement of the amount of saliva which has been secreted by the patient. Other than that, to know the pathology of the patient and to also examine the cranial nerves, we can go for a MRI scan. And if we are suspecting any head and neck deformity, we can go for a CT scan also. There are various subjective scales used for the assessment of severity of drooling. One of the most common scale used is the drooling severity and frequency scale. It has been widely used for the assessment of severity of sialorrhea. It contains two parts. First is frequency and second is severity. On the frequency part, there can be no drooling, occasional drooling, frequent drooling, and always drooling, and we grade them as 1, 2, 3, 4. On the severity part, there can be no drooling. The second grade 2 will be lips wet and wet, that is mild. Grade 3 will be drool reaches chin, that will be moderate. Severity 4 will be neck and clothes are wet, and severity 5 will be surrounding areas are also wet. So these are This is one of the scales which will be used for the assessment of Sialorrhea. So after assessment of the patient, what will be the issues faced by the patient? Because as such, it's just hypersecretion or the saliva coming out of the face. So what will be the issues faced by the patient? So we have divided them into physical and social and complications. Coming up to the physical complication, it will cause perioral chapping or rashes or macerations. It can lead to secondary infections in the oral cavity or the surrounding area of the face. It can lead to aspiration and pneumonia because there will be soaring different reflex defect. So it can lead to aspiration and pneumonia. Also, the hypersecretion can lead to aspiration and pneumonia. It can also lead to choking and poor oxygenation. Due to aspiration, there will always be poor oxygenation. So it can lead to that. Other than that, hypersecretion can lead to dehydration, and also it will lead to foul odor of the oral cavity. Coming up to the psychosocial complications, uh, it can lead to isolation of the patient. The patients might not want to interact with other people because there might be foul smelling oral cavity. So they might not be comfortable going away, which will lead to the isolation of the patient. There, it will also act as a barrier for socializing the patient. It will cause increased dependency and level of care. It will be, as we all already seen, degenerative disease are one of the major causes of Sialorrhea. The patient is already very dependent on the caregiver for that. So adding another symptom will also lead to increased dependency and level of care. And it will also lead to stigmatization of the person and the family. It's not only the person that is stigmatized, it's the family and the caregiver also which is stigmatized. So by the society. So it is important that we take care of all these psychosocial issues. In all these factors, both physical and psychosocial, lead to poor quality of both patient and the caretakers. Coming up to the management part, the treatment of Sialorrhea is best accomplished by using a team approach. As we already said, the assessment needs a multi-team approach. So management will also require a multi-team approach. The impact of Sialorrhea on the patient's quality of life is the most important factor in determining the necessity of therapy, and it will also impact the type of therapy we give, be it a pharmacological therapy or non-pharmacological therapy. For minimal problems in children under 4 years of age or in adults with unstable neurological conditions, observation is the best option. That is, if there are minimal problems and if the patient is under 4 years or the adult who is not stable enough to require any pharmacological or non-pharmacological management, the best we can do is observe the patient and see what happens next. Other than that, non-pharmacological and pharmacological treatment modalities can be used. Coming to the pharmacological treatment, on the drug side, anticholinergic drugs are one of the mainstay of the treatment. We have seen that Sialorrhea does not have a lot of treatment options. The treatment options are very limited. And also there have not been many studies regarding the treatment options also. So anticholinergic drugs are one of the mainstay in the pharmacological treatment. That is because the parasympathetic innervation of the salivary glands and acetylcholine is responsible for that parasympathetic innervation. So they block the acetylcholine, and by that they decrease the salivation. But we all know that anticholinergic drug come with their own side effects. So they are already contraindicated in patients with glaucoma, obstructive uropathy, gastrointestinal motility disorders, myasthenia gravis, and also they are very poorly tolerated in old age. So as we know, anticholinergics have side effects like they aggravate glaucoma, they cause urinary retention, they can decrease gastrointestinal motility. So therefore, they are already contraindicated in those things. The most common Anticholinergic drugs which are used are glycopyrrolate and scopolamine. So coming up to the dosing of these drugs. So glycopyrrolate can be started on the dosing of 200 to 400 mics per oral TDS, and it can be increased up to 1 mg TDS dosing. Hyoscine hydrobromide, which is also it's a transdermal patch. Scopolamine patch is present in the market. So that patch comes of 1.5 mg and it gives almost 1 mg of drug for 3 days. So the transdermal patch can be applied for 3 days and 72 hours and can be replaced later. Maximum of 2 mg of patch can be applied for 3 days. Other than that, atropine eye drops can be used. The eye drops which are used for dilatation, they can be used. 4 drops of tongue, four drops can be put in the tongue or sublingually up to 4 hours. They are not commonly used, but they can also be used. Other than that, amitriptyline can also be used. It has anti-muscarinic effects. Therefore, it is can be indicated in the management of sialorrhea. It is basically a side effect of amitriptyline, which we are here using for the use in sialorrhea. Amitriptyline can be started with 10 mg OD dose, and if the patient is tolerating that, can be increased up to 25 mg every 1 to 2 weeks till the maximum dose of 150 mg is reached. Other than that, one of the mainstay of the treatment is botulinum toxin injection. Now there are 2 types of botulinum toxin, toxin A and toxin B. Both of these can be used in sialorrhea. The most common use is botulinum toxin A. Intragranular injection of botulinum toxin A is used. It is used under ultrasound guidance and injected into the bilateral parotid and submandibular glands. The major side effects include pain at the injection site and excessive oral dryness. It is a very effective modality to deal with sialorrhea. As we also saw that most of the patients with sialorrhea may also have gastroesophageal reflex control. So it is very important to control GERD. Many developmental delays and or neurological impaired patients already have GERD. So we have to decrease this reflex for hypersalivation. Other than that, we have already seen that xerostomia is one of the major side effect of radiation therapy. So when we are dealing with sialorrhea, which is excessive salivation, so radiotherapy can be one of the treatment modality. It is a reasonable treatment modality in the patients who are not the surgical candidates and who cannot tolerate medical therapy, just like very old age patients who will not as the mainstay of medical treatment is anticholinergics, and the patients who cannot who will not tolerate anticholinergics, they can be given radiation therapy. So radiation produces xerostomia, which will last up to months to years. So in those elderly patients, it will give proper xerostomia and proper relief from sialorrhea for years, months to years. Other than that, coming up to surgical management, the surgical management is mainly indicated when there are any anatomical abnormalities present, just like macroglossia or adenotonsillar hypertrophy. So at that point of time, surgery is indicated to correct those anatomical derangements. Other than that, we can do surgeries on the salivary glands, and we can either denervate or we can remove the salivary gland from the body. Surgery on the salivary gland and duct and surgery to denervate the gland are one of the most common modalities used. When we denervate the gland, it is only it has been seen that it is only useful till 6 to 7 months, as the nerve will regrow and the salivation will start in 6 to 7 months after the denervation. But removing the salivary glands is one of the most definitive treatment for sialorrhea. The most definitive treatment of salivary is surgery to excise the major salivary gland or to ligate or reroute the major salivary ducts. So that was about the pharmacological and medical treatment of the sialorrhea. Coming up to the non-pharmacological management, whenever possible, especially when the sialorrhea is mild, non-pharmacological management is preferred over any pharmacological treatment. For orthodontic procedures for maloccluded or malpositioned teeth or jaw, palatal stimulation plates can be used. The palatal stimulation plates, what they do is they have wired and electric impulses which are attached to the soft palate, and they induce the swallowing reflex. So by inducing the swallowing reflex, they can prevent sialorrhea. Other than that, neurosensory stimulation, especially in patients with insufficient tone of oral muscles, can be used. It results in improved oropharyngeal reflex development. Now, neurosensory stimulation includes various different types of exercises, uh, which will help in increasing the tone of orofacial muscles. It will also include the sensory stimulation part comes giving various sensory stimulation to oral or oral pharyngeal area or palatal area. Uh, the examples can be giving vibratory sensations to around the face and around the oral area, which might improve the swallowing reflex. So in all, what we are doing here is we are improving the swallowing reflex by neurosensory stimulation. Other modality in non-pharmacological management is functional dysphagia. Functional dysphagia is helpful in patients with oropharyngeal dysphagia, resulting in inability to swallow saliva. What it does is it helps in reduction in episodes of aspiration and pneumonia, results in reorganization of motor cortex in patients with brain pathology. And there are three main parts of functional dysphagia therapy. It is restitution, compensation, and adaptation. Restitution is also called indirect swallowing therapy. So what is does is first a stimulus is given for the swallowing part, and the abnormal responses are assessed in restitution. So when the first of all we try to correct the abnormal responses by various exercises. Then as the stimulus is given, the swallowing reflex is also initiated. And at that point of time, movement of each part, like oral phase of the swallowing and pharyngeal phase of the swallowing, is monitored, and the abnormalities are recorded, and the responses and by that we can assess and compensate the abnormal reflex which is there, which it can be corrected, especially by any exercise or the neurosensory modulation which has already been discussed. In the compensation parts, there are alternative ways to control swallowing if the patient is not responding by restitution method. What happens is we can ask the patient to use other modalities for swallowing other than the usual swallowing reflex. It can be by supraglottic swallowing or effortful swallowing. As we said, the pharyngeal and esophageal part is involuntary. So we can do effortful swallowing so that the patient has to swallow by different alternative pathways. The third part of functional dysphagia comes in adaptation. So in adaptation, it includes change of diet. We can use the food and diet which can be easily which will be easy for patient to swallow. So functional dysphagia therapy consists of restitution, compensation, and adaptation. Other than that, biofeedback and automatic cueing techniques are also helpful. These are basically used in mild diseases. So automatic queuing technique is like wiping off faces with beeps or alarms. So alarm is put, it can be of different time period in the day. So whenever the alarm beeps, the patient is asked to wipe off the face. It is basically habit forming, and it becomes less and less effective with as the time passes. Other than that, biofeedback like positive reinforcement and negative reinforcement can be done. When the patient uses the automatic cues, the patient can be given the positive reinforcement so that he is getting habituated with it. And if the patient, that there can be negative reinforcement also when the patient has sialorrhea. So all these are non-pharmacological methods of uh, to control sialorrhea. Other than that, there have been various studies which have said that acupuncture is also effective, but there are no proper studies which have seen that. Uh, Other than that, the posture support devices like headback wheelchair, as is shown in that diagram, can be useful in controlling sialorrhea. So as the topic is very small and there have not been much of the studies conducted and much of the data available for sialorrhea. So only there are limited pharmacological and non-pharmacological management available. So coming up to the summary, it is a debilitating symptom which is often ignored. It's not only ignored by the patient, also ignored by the physicians. Hampers patient quality of life, both psychosocially and physically. Limited treatment options are available and low number of quality researches are present at the moment. Non-pharmacological options should be explored with mild conditions whenever possible, and if the sialorrhea is controlled by non-pharmacological modalities, it has to be used first, and then only to jump for pharmacological treatment, because uh, first the therapeutic part is limited to anticholinergics, which has other side effects also. And other than that, the other parts like radiation and surgery and botulinum toxin, they are invasive procedures or can cause any other side effects. So pharmacological treatment can be effective, but can often come with side effects. Thank you. That was for the presentation part.
Thank you so much, Bhavesh. It was a really comprehensive presentation. So Bhavesh has actually covered not only the management, but also the etiology, the mechanism. So to summarize, it is important for us to examine the patient, take a good history, because etiology is really important. Sialorrhea could be a result of hypersalivation also, that is increased production, or it is decreased swallowing. So any problem with the swallowing reflex. So that is why it is important to examine the patient, to take good history, and only then we will be able to manage the patient better. So not just that, the management options that he has mentioned includes not just the pharmacological, which is obviously the most important part for us as physicians, but also interventional management, non-pharmacological management. So that we will know that there are other options and we can refer the patient to the right place when pharmacological management does not work, especially in cases with neurosensory dysfunction. Uh, these patients will have to be managed not just with pharmacological, but also biofeedback mechanisms, um, uh, neurosensory stimulation training. All these things will also work. So we are open to questions. There is
Anuja,
one,
there are few questions in the chat box.
yes, ma'am. So there is one question. Very good presentation. Please tell us the amount of Botox for intraglandular total amount. So there are limited studies on this. This is usually done by an interventional radiologist. However, the dose for Botox ranges from 20 to 30 units for each gland. Mostly a higher dose is given for parotid gland, and a lower dose is because it's the biggest, and the lower doses are given for the other glands. Any other questions?
Any comments from anyone? Anyone wants to add in this topic?
हेलो
Yes, Dr. बताइए. Yeah, go
बस
ahead.
यही मैम, वेरी गुड प्रेजेंटेशन. मैं ये बता रही हूँ कि प्रैक्टिकली हमारे पेशेंट बहुत गरीब होते हैं, ग्लाइकोपाइलवेट टैबलेट अफोर्ड नहीं कर पाते हैं, तो हमने ये किया है कि हम 1 लीटर बॉटल में इंजेक्शन ग्लाइकोपाइलवेट डाल देते हैं और उनको 2 या 3 दिन के लिए बोलते हैं कि इससे कुल्ला कर लो 2 बार या 3 बार. इफेक्टिव होता है. ये हमारा प्रैक्टिकल वे है इसको साइलोरिया को करने का. तो एज एनेस्थेटिस्ट हमारे पास होता है ग्लाइकोपाइलवेट इंजेक्शन. हम उसको बॉटल में डलवा के 2 दिन करवा के छोड़ देते हैं. काफी पेशेंट को रिलीफ मिलता है. बस एक हमारा वे ऑफ डूइंग इट. आई जस्ट
Very
वांटेड
good.
टू.
So, can you introduce yourself? Who has said this?
आई एम डॉक्टर मधु फ्रॉम सफदरजंग हॉस्पिटल मैम.
Okay, very good, Dr. Madhu. Thank you. Thank you. Dr. Jennifer, you want to add something?
No, ma'am, very nice presentation. Nothing else. Thank you.
So I think this was a tough topic. Actually, I was thinking what Bhavesh and Anuja must be presenting today. So ultimately, what we can see that there are so many things to learn. And as Anuja and Bhavesh has given a lot of emphasis on knowing the etiology, as usual, all the symptoms, we should have first idea about the etiology, and then we should treat. And in this symptom, Sialorrhea, also knowing the etiology will make a lot of difference. And what I suggest that rather than going on pharmacological therapy, I think first, because we know that all the pharmacological agents, whether it is glycopyrrolate or Botox or amitriptyline, everything is going to have a worse side effects, I think. But it should not happen that dryness and side effects are making more troublesome life than the symptom itself. So we should try first non-pharmacological treatment, and then whatever possible. I'm not saying that all the non-pharmacological therapy will be possible in all the setups, but whatever possible, I think we should try non-pharmacological therapy first, and then simple pharmacological therapy, which is basically balancing the side effects of the medication, because there are side effects of all these medications. So it was a good presentation, Bhavesh. A lot of new things to learn for everyone.
Thank you, ma'am.
For residents, for seniors, for everyone. And thank you, Anuja, for waking up till 3 o'clock. I was just thinking, I will call you and ask you, but I knew that if you are not informed, means you are going to be awake and you will moderate this session. So now, thank you, Bhavesh. Both of
Thank
you
you,
have
ma'am.
done good
Thank you,
and
ma'am.
excellent job as usual. And thank you, Nisha and Archana. Thank you, everyone, for joining. We'll see you next week on next Monday before 6:30. Thank you.
ma'am.
Thank you, ma'am.
everybody.
Thank you, ma'am.